Hello and welcome to this video. My name's Kris, I'm an Australian GP, and I was one of the naughty GPs who was prescribing Ozempic off-label for weight loss before it became impossible to find. And I want to talk about it. I want to talk about why, I want to talk about how drugs like Ozempic work, and really just my thoughts and opinions on everything. So, you may or may not have heard of Ozempic. Ozempic's proper name is semaglutide, and it's known as a GLP-1 agonist. Long story short, it's a diabetic medication. It's used to reduce the general overall sugar within the bloodstream, therefore helping those with diabetes prevent complications of their condition and hopefully getting them to have normal sugars. It's been around for a while, and we've known for quite some time that it does also help with weight loss. Weight loss in itself can be very helpful for those patients of ours who are diabetic who also carry extra weight, because we know that there is a strong relationship between stored adipose tissue or fat cells and fasting blood sugar, that's what I meant. So it became quite known probably about a year ago, maybe a little bit sooner, in 2021, 2022, that the off-label use of semaglutide or Ozempic was actually doing something phenomenal for our patients who are dealing with obesity or at least being overweight in the weight loss space. So let's start with how it works. So GLP-1 agonists like semaglutide and its cousins, liraglutide, and there was a third one that I stopped prescribing because we couldn't find it. Anyway, brand names like Saxenda, it really was just Saxenda that I was prescribing otherwise, work in a multitude of ways. One way is it slows down the gastric emptying of the body. In English, what that means is when you eat, food sits in the stomach for longer, making you feel fuller for longer, and therefore you won't be as hungry. If you're not as hungry, you're not eating as much. If you feel full, you're not eating quantity, but also portion. Quantity as in frequency. You know what I'm saying, you won't eat as often or as much. Metabolically, it also increases postprandial insulin secretion. And again, in English, after you eat, it increases how much insulin your pancreas secretes. Insulin being the hormone responsible for binding or grabbing onto glucose or sugar and giving it to the areas that needs it. The brain, the heart, the muscles, you name it. If insulin and sugar don't bind, as is the case in diabetes, for example, or the tissue around is not sensitive to insulin, again, as is the case in diabetes, this sugar is then stored as fats and things like that. So Ozempic and its cousins reduce how much you eat by making you feel fuller for longer, and increase how much of that sugar is utilized and therefore not stored as fat. This is the very simple breakdown. It is a lot more complicated than this. Sounds like a miracle though, right? It sounds amazing. And people will tout that they lose a heck of a lot of weight on these medications, like 10 kilos in a week or something like that. That is never the aim when I was prescribing. And I can say on behalf of some colleagues of mine that I've talked to about this, it's not their aim either. Whenever we instigate any sort of method to lose weight, exercise, diet, medication, you name it, the aim truly is half a kilo to a kilo a week of weight loss. This is sustainable, this is healthy, and you're more likely to keep it off. If you lose 10 kilos and then do nothing, it's going to be disheartening and it's not healthy. It's just wrong. So whenever we started prescribing, again, I'm talking on behalf of myself and some colleagues I know who agree with me, it was always to have this slow weight loss, just like everything else. Speaking of everything else, I never prescribed it alone. I always spoke to my patients about healthy eating and lifestyle and exercise. And 99% of the time, I requested that they saw a dietitian to look at their food intake, to see where the hidden caloric intake may have been. Is it in their soft drink drinking? Is it in alcohol? Are they eating portions way too big for what their requirements are? Because weight is not simply calories in, calories out. but it is a component of it. And people say, yeah, I eat healthy, I eat a vegetable every day and some starch, and I don't get takeout. But then if you compare, they'll have a bowl of pasta and veggies, a bowl versus a bowl, there's a big difference there. So I'd always strongly recommend that my patients see a dietitian. I know a lot about nutrition. I don't know anywhere near what our dietitian colleagues know. So I'm very happy to say that's out of my scope. I can do a general review and make small suggestions, but that's about it. The second thing is I quite often ask my patients to talk to an exercise physiologist to get an exercise plan that suits them, something that makes them want to do it, that's enjoyable for them. There's no point me say go for a 30-minute run every day if you hate running. I hate running. I don't run unless I'm chased. But if you enjoy stationary cycling in front of the TV, if you enjoy dancing, if you enjoy swimming, how can we integrate that in your life? How can we break it up into small segments every day so you don't feel like going to the gym or whatever your preferred method of exercise is? It's like a big time commitment. It's a big, I don't have the time, because almost everyone has the time for some form of movement every day. And it's accumulative. You don't have to do 2 hours a day, 3 days a week. You can do 10 minutes every 6 hours or something. Basically, that's why I always suggest before I prescribe any medication like Ozempic that you speak to allied health professionals. The third thing that I would do is make sure that we had frequent reviews. And this is not a money grabbing thing. This is because these medications are not without risks, and they're not for everyone. So risk-wise, there is a risk that you will become quite unwell on this medication. The known side effects, I don't want to say messing with, because that's not the right term, but if we are changing the way that your digestion is naturally occurring, you can expect that you might feel nauseous, you might have vomiting, you might have diarrhea, and you might have constipation, you might have bloating, and you might have abdominal discomfort. So I need to know these things. I need to know, is it affecting you? Do we need to stop? Do we need to decrease medication? Or alternatively, if you've had no side effects and also no weight loss, do we need to start increasing? There was a very good guideline for how much we would increase Ozempic and Saxenda and all the other GLP-1 agonists for weight loss. Again, it's off-label, so it's not been approved for this, so it's a private script, not PBS subsidied, so it's a bit more expensive. But there was a good guideline, and generally it worked quite well for our patients. So I need to see that. The other things that Ozempic could do, it could predispose you to something known as pancreatitis. So I need to talk to you about what that might feel like. I should actually be doing blood tests before you start and during your treatment with it as well, to monitor to make sure you're okay. I did that for a lot of my patients, and a lot of them were needle phobic, so injecting themselves once a week and then getting a 3 to 4 weekly blood test was not their idea of a fun time, but they were doing it for their health. So I'm kind of jumping all over the spot. I've actually not scripted this. I've just seen a lot of posts about it recently, and I was like, I have an opinion and I have a platform, and 3 of you are going to see this video. But anyway, so let me just regather. So we've talked about what Ozempic is, how it worked. We've talked about the things that I would do before I prescribed it, the things that I would do whilst prescribing it. I haven't actually talked about the why yet. The reason why is not because I wanted to take medication away from diabetics, and not because I believed it was a quick fix for obesity and being overweight. I actually like to subscribe to the HAZE approach, the health at every size. You can be ridiculously healthy with a BMI that's over the normal, because BMI is flawed. Yes, there are lots of things that can come with being in a bigger body that negatively impact your health. Increased risk of diabetes, arthritis, you name it. So if a patient comes to me and wants to reduce their weight for health reasons, then I am very happy to oblige and help them on their journey. If someone's like, I've got a sore back, sore knees, my dad died of a heart attack at 30, okay, that was a bit extreme, but you know what I mean, then I'm not going to be like, well, you can be healthy at every size. Of course you can, but you also have a goal, and I want to help you there. I never prescribed Ozempic for anyone who wasn't considered to be overweight or obese. In fact, there was no real guideline for what BMI cutoff you should be, but I developed one myself because I think, there has to be a line somewhere. And I get very frustrated when I see people with a BMI under 25, who's considered normal size, on these medications, or at least being commenced on them. I know you can lose weight, and then we'll talk about getting off at another time. But yeah, it just didn't feel right, because to me, that seemed more purely cosmetic, because the risks then decrease substantially once you're within that normal BMI range. Again, as flawed as it can be. So I would do that to help people meet their goals. But also, we know there are complications to being overweight and obese. We know one of the biggest risks is diabetes. So why not utilize a primary or secondary prevention method to reduce that risk, versus waiting for you to have the disease and the complications to then give you the medication? Like, to me, that doesn't make sense. If someone's pre-diabetic or is got metabolic syndrome or is, genetically predisposed to having diabetes, and they want to come in and prevent that, and prescribing this medication would help that, why would I wait for them to have diabetes to help them? It was something that I had to juggle with, and not everyone subscribes to this line of thought, and I'm completely fine with that. I appreciate I may actually be in the minority. I appreciate that some may agree with me and some may think I'm silly. That's fine. This is how I justify things. This is my clinical judgment, my clinical reasoning. So the other thing is, Ozempic and similar drugs are one of the better things on the market for weight loss. And I wish there was a pill that, you lose weight, everyone's happy and dandy, but they're not. Duramine or Duramine, whatever you want to pronounce it, I never prescribe it. It's legal meth. Don't like it. Don't like the side effects. Don't like the data. You gain weight as soon as you come off it. People abuse it. It's just not worth my time. Things like Contrave, if cravings are a big deal, can be helpful and beneficial in a multidisciplinary approach, similar to how I approach Ozempic patients. Really, there's not much else out there. So this was one of the better things, with the better risk versus benefit profile being more in the benefit, and something that I could help monitor and have a bit of control over. Because if someone became sick, we stop it then, or we reduce dose or whatever. So do I feel bad that I potentially contributed to diabetics not getting their medications? Yes, absolutely. It's not a nice feeling at all to think that you've contributed to a shortage and people not being able to get life-saving medications for them. Where my frustration lies further, though, is not on my personal prescription, as in prescribing it, but in the fact that it sounds like, and this is complete conspiracy theory, I'm sure, but the parent company of semaglutide or Ozempic was like, oh, we can capitalize on this. Let's bring out another drug specifically for it and make a demand for it. And again, that's completely conspiracy theory. This is what I've heard through multiple different streams. So from pharmacists, from drug reps, from other GPs, from bariatric surgeons. However, I have no evidence of this. So, however, I just want to make that very clear. I'm not saying this is actually the true story. This is what I've heard. But that thought alone frustrates me so much that I cannot understand how there is a worldwide shortage. Anyway, I'm not going to dive into the conspiracy and stuff, but that's where I'm frustrated. Where I'm frustrated is that there was no increase in supply when there was an increase in demand. It's probably the easiest way to say it. So do I now prescribe Ozempic? For my diabetics, yes. For everyone else, no. Because I'm not taking it away from the patients who need it most, who have the correct clinical indications to have it subsidized. Absolutely not. I've seen so many of my poor diabetics have their sugars go backwards because we can't get our hands on it, or they don't tolerate other medications, and that's just not what I'm about. I will, however, be prescribing Wegovy or Wegovy, whatever it's called, if and when it comes to Australia and is approved and PBS subsidied, because that's what its indication is, right? Because I do think medication can have a role in weight loss. Some people try and try and try and cannot lose weight otherwise. And if they're doing it for the right reasons, health reasons, why would I stop that? I will prescribe it in collaboration, there's the word, in collaboration with other health professionals like dietitians and exercise physiologists, not just, well, continue eating whatever you want, take this injection, you'll be skinny, sweet. That's not what I'm about. So this has become, I knew it was going to be a rant. I knew it was going to be a ramble. But I'm just frustrated for people, for the diabetics who are now missing out on better health outcomes because some of us were prescribing it off-label. But I contributed to the problem. It's me. Hi, I'm the problem. It's me. But I did it with the best of intentions. I don't regret prescribing for the patients that I have helped. And I've helped quite a few. And it's the little things. It's not just, look at me, I'm a size 8 now. It's, I'm sleeping better. I'm not snoring. My sleep apnea is reduced. My arthritis pain is reduced and I can do more with my kids. I'm saving money on grocery bills is probably not because everything's so inflated at the moment, but I'm not late night snacking. I have more energy during the day. There's just so many things outside the aesthetics of weight loss that I'm really happy I can help contribute to. All in all, I'm really frustrated by the situation and I feel for people on both sides. Those who say that we should have never prescribed it off label, I kind of get it, I do. Because like I said, I'm the problem. I've helped contribute to this lack of medication for those who need it. I also see it from the side of, there should have been more supply when there was a demand, but I'm sure there are multitudes of reasons that I'm not privy to for this. I feel for both patients who needed it for diabetes and who wanted it / needed it for weight loss. I feel basically it's just a mess. So hi, I'm Kris. I'm a GP that prescribed Ozempic, and I will consider re-prescribing it in the future for weight loss, depending on things like price, availability, my other patients, other alternatives like Wegovy. Again, I've read it, I've never heard it pronounced properly. And the weight loss space is a really interesting one to be in. It's a bit of a controversial one. I'm still learning as well about the Hayes approach. I'm still learning about how to speak about someone sensitively without coming across as fatphobic or anything, because I'm not. I'm just trying to learn the nomenclature, the language, to make not only my patients comfortable, but also other health professionals. It's an interesting space. So anyway, thank you for sitting through this 15-minute rant. Maybe you learned something about Ozempic, maybe you didn't. Maybe you learned something about why some of us did prescribe, maybe you didn't. Anyway, I think I'm just gonna stop talking now because I think I'm going through my head, I'm like, oh, I should have talked about the other risks and things, but really, I'm not here to educate you about Ozempic and sell it to you. I'm here to tell you about why I was doing what I was doing. So that's that. If you have any questions, let me know. If you have any video suggestions, let me know. Any rants you want me to go on, I may get them myself. But until next time, guys, stay safe, stay healthy, and I will see you in a video very soon.